Kolkata. Dando nahi hota, banduk. First we have Mr. Prasad, just mute the others.
Yes, ma'am. Yes, ma'am.
Yeah. So today we have esteemed guest faculty for the case presentation. First, yeah, just mute others, please. Yeah. So we have Dr. Varghese Koshi. He's a senior rheumatologist in Armed Forces Medical College. He's an alumni of BJ Medical College and Sassoon Hospital MBBS, MD Internal Medicine from AFMC. Subsequently, he had 2 years training program in clinical immunology and rheumatology at CMC Vellore. He has had many publications in international and national journals, co-author of the BMG course in rheumatology, and his student won the Best Poster Prize at IRECON 2024. He has had various appointments at MH Golconda, Jodhpur, and in even the UN mission in Sudan. Presently, he is the HOD of rheumatology at Command Hospital, Pune. Along with him, we have Dr. Aditya Burje. He's a young and dynamic rheumatologist practicing at Akola. He's an alumni of GS Medical College, KM Hospital, followed by his tenure and of MD DNB and Rheumatology Fellowship at Sion Hospital. The student today is Masaswini Edara. She'll be presenting the case. She's from DY Patil Medical College, and her guides are Dr. Girish Kakade and Dr. Digvijay Egbote. Over to you, Dr. Koshi and Dr. Aditya. Dr. Masaswini, you can start the case. Yeah, go to PowerPoint. Go to slideshow. Yeah.
Good morning, Dr. Masaswini. Good morning, everybody. Good morning, Alakendu sir and Kavita ma'am.
Good morning, everyone. Ma'am, can I start, ma'am?
Yeah, please start. So it's like a usual case presentation. You can stop her in between the history or after history, then, examination, etc. And both of you can ask questions turn by turn. Over to you, Dr. Koshi and Dr. Aditya. Yeah.
Yes. Right, Doctor.
Can I start, sir?
Yeah, Dr. Masaswini, I think you should start. We'll probably ask you questions along the way. Okay, or at the end of your history, we'll probably go back and then, analyze the history.
Yes, sir. Today I'm presenting a case of 48-year-old female, married housewife from Pimpri, Pune. She came with complaints of joint pain for the past 23 years and deformities in both hands and feet for past 15 years. So, history of presenting illness, joint pain started 23 years back around 2022, which was insidious in onset, gradually progressive, associated with early morning stiffness of more than 30 minutes, and initially involved 3 to 4 small joints of hands. Over the course of 2 years, it progressed to involve small and large joints of both upper limbs and lower limbs. Patient was initially prescribed painkillers by a local doctor, and patient was symptomatically better initially with painkillers, but later experienced persistent pain and swelling in the joints and worsening of early morning stiffness. And then she consulted a rheumatologist and she was then started on DMARDs, but patient was not compliant with medication. Later, around 2010, which is 15 years back, patient started noticing deformities of her hands initially. Patient noticed flexion deformity at the proximal interphalangeal joint of index finger and middle finger of both hands and ring finger of left hand. Later, the deformities were noticed in thumb finger of the left hand and little fingers of both the hands. And patient also noticed flexion deformities in the interphalangeal joints of the toes in both lower limbs over the course of time. And the deformities have progressed over 15 years. Now patient is having a loss of function in doing activities of daily living, and she can be classified under class 3 of ACR functional class. Patient doesn't have any history of low back pain, no history of redness in the eyes or blurring of vision, no history of heel pain, no history of swelling of entire finger, no history of nail changes, no history of recurrent diarrhea or blood in stools or nocturnal abdominal pain, no history of Raynaud's phenomenon, no history of photosensitivity and hair loss, no history of Zika symptoms or oral ulcers, no history of frothy urine or puffiness of eyes, no history of... No history of limb edema, no history of dyspnea, no history of widespread musculoskeletal pain. Past history, patient had history of scalp lesions when she was 15 years old. The lesions were in the form of reddish purple plaques with white flakes and excessive dandruff. No history of alopecia or scarring. Scalp lesions responded to topical therapy initially, but patient had recurrent episodes of scalp lesions, and once the patient was started on DMARDs, the lesions completely disappeared. No history of any comorbidities like diabetes, hypertension, tuberculosis, cerebrovascular accident, or ischemic heart disease, or psychiatric illness. Vaccination, patient is not aware of childhood vaccination, but patient 3 years back, she took 2 doses of COVID-19 vaccine. Family history, father has history of psoriasis, but no history of arthritis or inflammatory low back pain in the family, no history of tuberculosis in the family. Personal history, patient takes mixed diet, appetite is normal, sleep is adequate, no fatigue, no mood changes, no addictions. Menstrual history, patient attained menopause 2 years back. Socio-economic status, patient is a housewife, completed high school education, she's married, lives with, it is a nuclear family, lives with her husband and son. Annual household income is 15 to 20,000 per month, and insurance status uninsured. So, summary after history. So, 48-year-old female with chronic inflammatory polyarthritis associated with deformities with past history of probably scalp psoriasis and family history of psoriasis. So, I would like to consider my first diagnosis as psoriatic arthritis. Other DDs I want to consider are rheumatoid arthritis and sarcoidosis in this patient.
Right, Dr. Manaswini. So if
Yes,
we go back to the, at the history stage itself, when
yes,
we have this middle-aged lady who has come to you,
yes,
what would you've already said that your first differential diagnosis would be psoriasis.
yes,
Uh,
sir.
but, like how would you describe the musculoskeletal involvement of her joint pains and swelling which has taken place, the arthritis? Would you
Yes, sir. Initially, sir, 23 years back, it started as oligoarthritis, sir. It involves small joints, basically interphalangeal.
when will you call it, a very basic question, when will you
Yes,
call
sir.
it oligoarthritis?
Sir, involvement of 2 to 4 joints is called oligoarthritis, sir.
Less than four joints.
Less than 4, yes,
Four
sir.
or less than four joints, and more than four joints would be polyarthritis.
Polyarthritis, yes, sir.
So, can you give us a few differential diagnoses towards oligoarthritis?
So reactive arthritis, psoriatic arthritis can present as oligoarthritis, and even initial stages of rheumatoid arthritis initially can present as oligoarthritis. Gout can present as oligoarthritis, sir. And um,
Right.
uh,
Yeah.
CPPD crystal arthropathy can also present as oligoarthritis.
Fair enough. Fair enough. So, so the spondyloarthritis peripheral variants could present as oligoarthritis, and even like you brought out gout. Of course, initially, what would the typical presentation of gout be? I mean,
Sir, initially it involves usually it involves first MTP joint, sir, MTP or MCP joint,
podagra.
and podagra. Yes, sir, and it comes in attacks of severe episodes, sir,
Right.
and
So,
then later it can progress to oligo and polyarticular gouts.
and it could be associated with tophi and other features. Could it
Yes, sir.
result in axial involvement, gout?
Yes, sir. Gout can also cause sacroiliitis and spondylodiscitis also, sir.
Correct. So now, if we look at this lady, so she predominantly, you would say she had a peripheral appendicular skeleton involvement, isn't it?
Yes, sir. Yes, sir.
Right. And how would you describe it? Would you describe it as additive, or how would you describe the arthritis?
Um, Sir, it
So,
gradually progressed into polyarthritis, sir. Initially, it
so
is
it was an
oligoarthritis.
additive symmetric
Additive symmetry. Yes, sir.
inflammatory polyarthritis, and probably deforming. There were deformities which were
Yes,
developed,
sir.
isn't it?
Yes, sir. Yes, sir.
So, could you name some arthritis which would result in a non-deforming kind of arthritis?
Sir, SLE, sir, and Sjogren's syndrome,
Yeah,
and
the
MCTDs usually can present with. non-erosive arthritis without any deformities.
Yeah. The eponym for the SLE arthritis, what's it known as?
Jacob's arthropathy.
Correct, Jacob's arthritis. Right. So if what else could this scalp lesion that this lady had, be other than psoriasis?
Sir, could be seborrheic dermatitis, the way she described as scaly lesions. But seborrheic dermatitis usually presents as yellow oily scales, and usually those doesn't cross the hairline. Scalp psoriasis lesions usually tend to cross the hairline, and they're more itchy with can be associated with hair loss.
Right. So can you go back to your negative history of the?
Yes, sir. Yes, sir.
So did you take for? Did you ask her for history of lesions anywhere else? What would the classical distribution of psoriasis be?
Sir, psoriasis usually occurs on the extensor surfaces, sir, over the body, on the elbow, extensor surfaces of elbows and knees.
Right.
And
Anywhere else?
gutted psoriasis can occur in on the trunk and limbs, and there is inverse psoriasis, sir, which occurs on the flexural surfaces. And there are some hidden areas which we have to look for, like gluteal clefts and behind the earlobes and axilla mammary folds in female patients.
And the
And
umbilicus.
umbilicus, sir,
And even
periumbilicus.
the external auditory canal sometimes, may have psoriatic skin lesions. So
Yes, sir.
probably this gives us a clue that we should look for those lesions in this
Yes, sir.
patient. And did you ask for any pitting of the nails?
Yes, sir. I have
Any
asked, sir. No, sir. No nail changes are seen in this
no
patient.
nail
Sir. No
changes.
nail.
Right. And so when you ask for history of redness in the eyes or blurring of vision, what are you
Yeah.
trying to?
Sir, usually either in rheumatoid arthritis usually associated with the scleritis and episcleritis, sir, and psoriatic arthritis usually associated with uveitis.
Correct. Correct.
Yeah.
And
Aditya, would you like to ask anything?
Yes. Which chronic infection is associated with deforming arthritis? Like you said, the patient has deforming arthritis. So which
Sir, tuberculosis.
and anything else? Along with, I will give you a clue. It is associated with neuropathy also.
Sir, leprosy, sir.
Yeah. So,
Yeah, continue, Dr. Koshi. Yeah.
yeah. So so now when you ask her for dyspnea and breathlessness, so why did you ask her for breathlessness?
Sir, to rule out ILD and PAH in these patients, sir, to rule out CTD features.
So you wanted to
And
rule
also,
out? Yeah, please go ahead. I hope I'm not intimidating you with my questions.
no,
I
sir,
just try
not at all,
to,
sir.
take it towards some kind of a logical
So
conclusion.
please ask.
Yes, sir. Yes, sir.
Learning.
Yeah. So, the dyspnea you would limit it to interstitial lung
Sir,
disease.
and cardiac involvement also, sir.
Yes, there could be accelerated cardiovascular disease, which could, and multiple forms of cardiovascular. So,
Yes.
in psoriatic arthritis or say the spondyloarthritis subset, what kind of cardiovascular disease are we expecting?
Sir, these patients are prone for premature atherogenesis, sir, so they're more prone for IHD. And also in axial spondyloarthropathies, patients can have aortic insufficiency and ascending aortitis, and also pericarditis can also be there, sir, with diastolic dysfunction.
Very true, very true. And is psoriasis associated with any kind of other illnesses, the chronic diseases, any other illness which could be associated with psoriasis and psoriatic arthritis?
Sir, psoriasis is usually associated with metabolic syndrome, sir.
Yeah.
Yeah.
So we have to check for hypertension, blood sugar levels, and fasting lipid profile and liver enzymes often in these patients.
Anything that you would start looking for in the general examination, which I might expect that you should be.
Sir, BMI and waist hip ratio, sir.
Very true. Any other markers of, metabolic syndrome?
Sir,
You tell us about
acanthosis nigricans,
insulin resistance, markers of
insulin resistance. Yes, sir. And skin tags over the neck.
Gout also.
Gout, yes, sir. Gout, yes.
Right. And when you ask for Raynaud's,
Yes.
why did you ask for history of Raynaud's in this patient?
Sir, Raynaud's is very common phenomenon in MCTD, sir, and also myositis patients.
So how would you approach Raynaud's disease? Like in this patient, she's a 48-year-old, right? Suppose she had Raynaud's. How would you classify this Raynaud's?
Sir, it is associated with arthritis, so I would consider it secondary to any MCTD, sir.
So essentially, we'd probably classify Raynaud's as primary and
Primary
secondary,
and secondary. Yeah.
right? So, and this would generally be a secondary Raynaud's.
Yes, sir.
So, which is more of a problem, primary Raynaud's or a secondary Raynaud's?
So secondary Raynaud's, it is usually associated with ulcers and gangrene can happen.
And how will you differentiate primary from secondary Raynaud's? Clinical examination.
Clinically, sir, secondary Raynaud's may not have all the three stages of the. Sir, initially there will be pallor, and then there will be cyanosis, and there will be redness. So all the three stages may not be present in secondary Raynaud's.
And what else?
And there will be nail fold capillary changes can be seen in secondary Raynaud's, sir.
Okay. And symmetry?
Symmetry, sir, primary could be unilateral also, sir, asymmetric. Secondary is...
No, you got it exactly the other way around.
Oh, so sorry. Secondary. Okay.
Why do you think we are insistent on asking you about primary and secondary Raynaud's? Okay, let me just put it this way. Suppose you diagnose, because first of all, this lady is which age bracket would primary Raynaud's be more common in?
Younger, it's around 20 to 25 years
Yes.
old.
Yeah. And so, you see, what is the premise? Once you say diagnose, I know this is more a hypothetical, not directly related to this case.
Okay.
But suppose you diagnose primary Raynaud's in a young lady who's about 18 or 20 years of age. So,
yes.
Will you be just telling her that not to worry? That's it? It's primary Raynaud's, so less chances, so nothing to worry.
Yes, sir. It is not usually it is not associated with any other features.
No. That's precisely my point. See, actually, once you diagnose a primary Raynaud's, the diagnosis is tentative because this patient needs to undergo an ANA evaluation. This patient also needs to undergo a nail fold capillaroscopy. So if there is nail fold capillaroscopic changes, it of course immediately shifts your diagnosis. It's likely to be a secondary Raynaud's. And you will have to keep following up that patient at regular intervals with, nail fold capillaroscopy at least as the minimum. 6 months to 1 year. I'm not sure of the exact recommendation, but I'm not sure whether there is an exact recommendation, but something like that. You need to keep them under follow-up.
Okay, sir.
Yeah.
Right. So at the end of it, what do you feel? What's your opinion what is this patient? What do you think she fits into?
Sir, if there are no scalp lesions, I would have considered rheumatoid arthritis, sir. But there is a classic history and family history of psoriasis also. So I would like to consider my first differential as psoriatic arthritis.
Fair
and
enough.
Then rheumatoid arthritis, sir.
So tell me, how would you, are there any other conditions? Suppose this was a younger lady with scalp lesions.
Okay, sir.
Presenting more acutely. Then would you think of psoriasis? And you've already mentioned psoriasis and...
yes, sir.
But any other condition you'd like to think of?
Discoid lupus, sir.
Yeah.
But that usually it causes scarring alopecia.
Right. 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 And how would you define the axial skeleton versus the appendicular skeleton? I know it's a very basic question, but I'm not sure at the DM level it is relevant, but still,
Axial skeleton is the spine and the sacroiliac joint, sir.
right. So the vertebral column, the
But
craniovertebral junction, the sacroiliac joints, any other joint?
And
so hip joint.
No. The hip and the shoulder are root joints.
Okay.
Then they would still qualify. I mean, so my reference is Hoshwar.
Sternoclavicular joint, sir.
Yes, the
Sternoclavicular.
sternoclavicular joints would qualify as axial skeleton.
Axial. Okay.
So even historically, I mean, I think we need to have a framework so that we are clear when we, of course, this patient doesn't have any of those, so it's fair enough. What about the TM joints and the cricoarytenoid joints?
Sir, patient doesn't have any swelling or pain while chewing or
Yeah,
opening the mouth, sir.
there's no history of
There
hoarseness
is no
of
history. Yes, sir.
fair enough. So I think we can, Dr. Aditya, shall we go on to the examination or
Yes.
would you like?
Just sir, I just wanted to ask if this patient did not have like scalp psoriasis or scalp lesions, and what other symptoms are important, like in chronic arthritis, like asking for frothy urine and puffiness of eyes regarding
Uh, yes, sir.
symptoms
Rheumatoid arthritis, chronic arthritis usually associated with secondary amyloidosis, sir.
and anything else?
And if patient doesn't have scalp lesions, one of the diagnoses can be SLE also. So lupus nephritis can also be there.
Oh, okay.
And in psoriatic arthritis or seronegative spondyloarthropathy is usually associated with IgA nephropathy.
Okay.
And the patient must be using a painkiller, so NSAID-induced nephropathy can also cause CKD in this patient.
So one more question, Dr. Manaswini.
Yes, sir.
When we ask for history of swelling of the entire finger,
Yes.
so what are you indicating by this?
Sir, history of dactylitis, sir.
So can you name some differentials for dactylitis?
Yes, sir. Seronegative spondyloarthropathy is most common in psoriatic arthritis, and tuberculosis is one of the differentials, sir. Sickle cell disease.
Right.
Sarcoid and gout can also cause swelling of
Sarcoid
entire.
seems to be a favorite with you. No, I'm just on the lighter side. So yes, how would you differentiate, say, dactylitis from puffy fingers in MCTD, mixed connective tissue?
Sir, there will be the dactylitis is usually painful, sir. Painful condition.
Correct, very
With
true.
tenosynovitis of flexor sheaths, and even there will be periarticular soft tissue involvement also, edema and swelling.
Fair enough. Fair enough. So shall we proceed, Dr. Aditya?
Yes, sir. Yes.
On a general physical examination, sir, patient's BMI is 20 kg per meter square and waist to hip ratio is 0.79, which is normal. And vitals, pulse rate is 86 beats per minute, regular, normal volume, normal character, no radial delay, no radiofemoral delay, and all peripheral pulses are well felt. Blood pressure is 128/70 mmHg in right arm supine position. Respiratory rate is 18 cycles per minute, and temperature is 98.6 degree Fahrenheit. And there are no signs of pallor, icterus, edema, and lymphadenopathy. And on examination of hair, there is no scalp psoriasis at present or excessive dandruff, and no alopecia. Eyes examination is normal. Oral cavity is also normal. Nails, there are no nail changes. Skin, no evidence of skin psoriasis at present, even in the hidden sites. Musculoskeletal examination, peripheral joint affection. When patient presented, she had tender joints, two tender joints, right wrist joint and left knee joint. And swollen joint is one, which is right wrist. And deformities that are seen are Z deformity is seen in left thumb, ulnar deviation of the index and middle fingers at the PIP joints of both hands, and swan neck deformity is seen in the little finger of the left hand, and there is a mild flexion deformity in the PIP joint of the ring finger of left hand and DIP joint of the right hand. And on the legs, we can see left second toe showing claw toe appearance and rest of the finger showing hammer toes. There are no signs of enthesitis, no signs of dactylitis, no signs of anterior uveitis, no psoriatic skin lesions, no nail lesions. Spine, no obvious abnormalities and spine tenderness, no SI joint tenderness, and Faber's test is negative on both sides. Mobility measures, modified Schobers, there is 8 centimeter difference, which is normal. Lateral flexion, both left and right side showing 12 centimeters difference. Occiput to wall distance is 0 centimeters, and intermalleolar distance is 110 centimeters, and chest expansion is 5 centimeters, which are all normal. There is no affection of axial skeleton. Systemic examination, per abdomen is soft, non-tender, no organomegaly, bowel sounds are present. Respiratory system, bilateral normal vesicular breath sounds, no added sounds. Cardiovascular examination, S1 is to heard normally, no murmurs, and central nervous examination is normal with normal power and deep tendon reflexes. Plantars are flexor response in both lower limbs. So summary after examination, 48-year-old female having chronic inflammatory polyarthritis with deformities and past history of scalp psoriasis with no axial spine involvement and no other extra-articular involvement.
So, Dr. Manaswini, can you go back to your general examination?
Yes.
So, of course, this, I catch my MD students on this. When you say no radial delay or radiofemoral delay, do you want me to go into that, or shall we just proceed towards more of rheumatology?
No, it's okay, sir.
But I think you should be careful. What do you mean by this radial delay? What happens?
Sir, there is the pulse difference between, in radial delay, pulse difference between right and left hand, sir. Or like it happens in coarctation of aorta.
You're right about the cause.
Yes, sir.
But what do we mean by the delay? If there is a pulse difference,
Yes,
then
sir.
that would mean there is an obstruction to that, right?
Yes,
So
sir.
it would start tending to move towards coarctation or Takayasu or things like that.
Yes, sir.
But
Yes, sir.
when we say, suppose I say there is a radial delay,
Yes, sir.
what does that mean? How do you measure it? And does it mean that the pulse in the peaking or something in the right, say radial, comes slower than the left, something like that?
So
No,
right comes earlier than the left, sir.
no, actually what happens is it's the rate of rise and the peaking which would differ. So it's not exactly, that there would be a time gap between the two.
Yes.
So that's what, so I mean, when you mention it, I would say that you should be clear on it. That's all that is.
Okay. Yes.
Can
Okay.
you go to the next slide, please?
Yes.
Right. Do you think looking for lymphadenopathy in this patient is important?
Sir, one of my differentials is sarcoidosis.
Right. So from that point of view, yes. Is there any risk? Suppose this was, say, suppose this patient also has, could this patient have both rheumatoid arthritis and psoriatic arthritis? Did you get my question, Dr.
Yes, sir.
Manaswini?
Yes, sir.
Is it possible that this patient has both rheumatoid arthritis and psoriatic arthritis? So
Sir,
if it
no.
was a RA patient, would lymphadenopathy signify anything to you?
Lymphadenopathy can be there, sir, as a extra-articular manifestation of rheumatoid arthritis.
Okay, and part of the activation of
Part
the
of.
endothelial activation.
Yes, sir.
Fair enough. But is there any transformation? Like you must have heard of Sjogren syndrome transforming into lymphomas? Like,
Yes, a non-Hodgkin's lymphoma.
yeah.
Non-Hodgkin's lymphoma is common in rheumatoid arthritis, long-standing disease.
So would you be aware of the percentage? How many percentage of, say, long-standing RA or RA would transform into lymphoma?
No, sir, no idea.
Right. And so out of the autoimmune connective tissue disease, which disease do you think has the highest transformation into a lymphoma? It's Sjogren's syndrome.
Okay, sir.
Yeah. Okay. Can you move to the next? And pallor, if suppose what kind of anemia would be, are you expecting in this patient?
Sir, anemia of chronic disease can be present.
Right.
And iron deficiency anemia can be present because of GI blood loss because of use of NSAIDs longer term.
Yes, very true, very true. Yes.
And patient, because of medications, if patient is started on DMARDs because of methotrexate, bone marrow suppression can happen, and that can also cause.
Yes, absolutely. Drug induced.
Yes, sir.
Yes. Can you go to the next slide? Can you please just go back, please? Next slide.
Yes.
How many, suppose this patient had pitting of the nails, when will you call it as significant pitting?
If the patient has more than 4 to 5 pits per nail, sir.
No, I don't think that's right. It's not 4 to 5. Not sure of the exact figure. Dr. Aditya, would you?
Yes, sir.
Uh,
There even nail in psoriasis.
I think it's something like more than 20 pits. I'm not so sure of that. Kavita ma'am is the
20 is correct, I think. Yeah. Around 20 is significant, yeah.
significant pits, yeah.
Minimum 20s.
Yeah. Can you next slide, please?
Yes.
So in this, what is the characteristic things? How would you separate? Suppose, are there any nodular lesions in the DIP and the PIPs?
No, sir, there are no nodular lesions.
So what am I trying to indicate? Uh, what are those nodes? Suppose there were nodular lesions.
Osteoarthritis, Herberdens and Burkhardt nodules can be present, sir.
Right.
In
Right.
PIP and DIP.
So the differential diagnosis of DIP involvement?
So DIP involvement is commonly seen in psoriatic arthritis. Reactive arthritis can also be seen, sir. And osteoarthritis, gout.
Yeah. So essentially, osteoarthritis and psoriatic arthritis should be high on your this thing.
Yes.
Moment there are nodular lesions, and how would you distinguish it from, say, synovitis and synovial hypertrophy? These nodular lesions.
Sir, there won't be any synovial thickening, sir. Puffiness won't be there around the joint. There will be.
The
So from
very
the
fact
nodules.
yeah, very fact that it is hard nodules.
Hard nodule, yes, sir.
Nodules would indicate. So the Herberden's nodes are on the distal interphalangeal joints and Bouchard's on the proximal
Yes, sir.
interphalangeal.
Yes.
Right. Can you go to the next slide, please?
Yes.
Yeah. Next slide. Yeah, I think you can go to the diagnosis now. Dr. Aditya, in case you want to.
No, sir. Yeah, fine. You can proceed.
Can you tell us some other tests for the Faber? What is the full expansion of the acronym Faber?
Sir, flexion, abduction, and external rotation of the hip joints.
Correct. Any other tests for distraction of the SI joints?
Sir, passive straight leg raising test.
Passive straight leg raising as a test for distraction of the SI joint? No, I wouldn't agree on that.
Oh.
I'm asking for, yeah.
Sacroiliitis, yeah.
Right. So actually, the sensitivity and specificity for these clinical tests of sacroiliac distraction is quite very average or moderate itself. So you have to do, actually, there are 5 tests. You can read on them. and
Yes, sir.
you have to have about 3 or 4 of them to achieve a certain degree of sensitivity and specificity. So many times you see orthopedic surgeons saying, there is sacroiliac tenderness on clinical examination. So
Yes,
that,
sir.
that will have to be taken with a very large pinch of salt. Um,
Okay.
yeah, because you have to actually, they have documented 4 or 5 tests are there, out of which at least 3 have to be there for you to achieve something like 70 to 80% sensitivity and specificity. So a single
Okay.
test would really tell us not much.
Okay.
And in today's era, we would want to image the sacroiliac joint.
Yes.
Yes.
Yeah, you can you continue? Next slide, please.
Yes.
Right. So do you think what could be the neurological involvement in this patient? Suppose this patient was to have some form of neurological involvement. What kind of neurological involvement would be there?
Sir, cervical myelopathy, compressive myelopathy, because of cervical spine is commonly involved in these patients.
Right. Very true. Both RA and the
And
polyarthritis could
correct.
have a AAD, atlantoaxial
Yes,
dislocation,
sir.
then could result in a cervical myelopathy.
Yes.
What else?
Um,
So do you see the neurological examination? I would be
yes, sir.
very keen on,
Peripheral
especially,
neuropathy.
yes, yes, such a long-standing
Yes,
patient
sir.
can have entrapment neuropathies and
Compartment. Yes, sir.
entrapments, various entrapment. It could be carpal tunnel or tarsal tunnel. It could be, multiple entrapments could be there.
Yes.
And could any vasculitic involvement take place?
It's a mononeuritis multiplex.
Right. So even a mononeuritis multiplex can, especially if it is an RA patient, at least we've seen a number of patients even now coming up with, how would the presentation be? Generally, a mononeuritis multiplex in an RA patient, how would it present as? You generally
Uh,
present like a wrist drop or a foot drop.
foot. Yes.
Yeah. So, and that becomes an emergency really, because it's like an angina. It's
Okay.
the cry of the dying nerve. You have to pulse that patient.
Yes.
Be rather aggressive on that patient. Fair enough. Can you move on to the next slide? Right. So, how would you like to investigate this patient, Dr. Manaswini?
Sir, investigations, routine lab tests, sir, CBC and complete blood picture and liver function tests and renal function tests and ESR and CRP as acute phase reactants, and also RF and anti-CCP to rule out rheumatoid arthritis.
Right. So, what percentage of psoriasis patients will have a rheumatoid factor positivity?
So rheumatoid factor around only 5 to 6%, sir. But more than rheumatoid factor, a low positive anti-CCP is common, more common. Around 10% patients can have in psoriatic arthritis.
Right. Right. And so, this is the blood test that you have focused on. What kind of imaging would you like to do this for this patient?
Sir, imaging of the small joints of hands with wrists and legs, and also sometimes psoriatic arthritis patients, they can have asymptomatic involvement of the spine in the initial stages. So I would also like to get sacroiliac joint and hip x-rays for this patient, and also cervical spine x-rays.
Right. So on your X-ray of the hands, what kind of changes, radiographic changes would you be expecting?
Sir, uh, decrease in the joint space, erosions, and also periostitis, sir. Newborn formation is common in psoriasis patients. Penicillin cup deformity can be seen, and also acral osteolysis can be seen where there is resorption of the distal phalange.
Okay, so
And arthritis mutilans.
yeah, arthritis mutilans is a kind of psoriatic arthritis which is there.
Yes.
So my question is, are there any radiographic distinguishing features between, say, an RA and a psoriatic arthritis on the hands? I'm speaking right now of the hands.
Sir, RA in the initial stages can have periarticular osteopenia, sir, which is not very common in psoriatic arthritis patients.
Fair enough.
And there could be ankylosis of the joint seen in psoriatic arthritis, sir, which is not there in rheumatoid arthritis. And DIP involvement is seen in
First is of course
psoriatic.
the distribution, that the DIP involvement is unlikely in RA, but not entirely unknown. And in the nature of the erosions,
Sir, erosions, marginal erosions.
juxta-articular erosions in terms, when it is juxta-articular erosions, it is RA. When it is, subarticular, then
Yes.
it is likely to be either OA or psoriatic arthritis.
Psoriatic, yes, sir.
And in the spine, see, how would you distinguish between, say, degenerative changes and changes due to, say, spondyloarthritis or psoriatic arthritis?
Sir, spondyloarthritis has a sacroiliac involvement, sir, which is and symmetric. Asymmetric involvement is seen in psoriatic arthritis, sir. And osteophytes are seen in osteoarthritis, degenerative changes, sir. And syndesmophytes are seen in.
So I'm asking you, what is the difference between osteophytes and syndesmophytes? What's the difference? They both look the same.
Sir, osteophytes are formed due to erosions, sir. And syndesmophytes are formed due to the calcification of the Sharpie's fibers of the annulus fibrosus, which get attached to the adjacent vertebra and get calcified. So around the margins and symmetrical syndesmophytes are seen in ankylosing spondylitis.
So anyway, do check. Even my knowledge is rusty, but my belief is that marginal osteophytes, that means from the exact margins of the vertebra, would represent osteophytes, that is degenerative osteophytes. And non-marginal, that means not slightly, say, below the edge, which start, they would represent more of syndesmophytes. And and of course there would be calcification, like you said, of the anterior longitudinal and posterior longitudinal.
Yes.
And those things can enthesitis.
Yes.
And anything on the pelvis, the ala of this thing, which would indicate to us that this is like, psoriatic arthritis. The bony margins.
Sir, whiskering of the iliac crest.
Yes, very good. That would indicate what?
Sir, enthesitis, sir.
Enthesitis, recurrent episodes of enthesitis. So these things would help us diagnose. Are we overshooting the time? I think it's 30 minutes for.
Yeah, it's now 10:43. We have 7 minutes more.
7 minutes, ma'am.
Yeah.
Right.
You can maybe discuss the treatment and give your feedback also.
Right.
Yeah.
So, Dr. Masaswini,
yes.
How would you want to go around treating this patient? How, suppose your tests are all RF anti-CCP negative, and the CRP is like kind of normal. And so, Dr. Aditya, what do you think?
Yes.
Because, in psoriatic arthritis, many times we have patients who have a CRP which is normal.
Yes, sir.
What are you going to do now?
So there is a polyarticular involvement, sir. So I would like to start the patient on conventional DMARDs initially. With
what patient is already on DMARDs, taking from physician or from private, and has
yes, sir.
OTPTs like in the range of 70s and 80s, how will
sir, TNF alpha inhibitors can be used in such patients, sir.
How will you evaluate first whether you'll?
Yes, sir. First, it could be drug induced or it could be because of NAFLD, sir. So I would like to proceed for an ultrasound and fibroscan of the liver.
No. Initially, what will you do? You will order first liver function test, complete liver function test initially, right?
Yes, sir.
Only OTPTs, you have only OTPTs with you. Then you will first evaluate whether this is only ST-LT elevation or whether complete liver profile is.
Yes, sir. So, serum proteins and INR levels.
Yeah, everything.
Yes.
All for some viral markers, right?
Yes.
We'll also see Hep B, Hep C also before
Yes, sir.
initiating TNF. You'll not directly go to TNF. First, you'll confirm this, and whether then how to proceed if it is because of drug induced.
So drug induced, we will stop the offending agent, sir. Methotrexate commonly causes liver enzyme derangement.
Okay.
And
Can cause liver.
sir, leflunomide can also cause.
Okay. Yeah. So, what are other conventional DMARDs that can be given if the patient is non-affording for, like, say, anti-TNF usage?
So sulfasalazine can be given.
Okay.
And
What about HCQs? Would you like to give HCQs to this patient?
sir, HCQs, they flare the skin psoriasis, sir. So usually we
Very
don't prefer
correct.
it.
It's a trap question. Good.
Yes.
Right. And now, one thing what Dr. Aditya said, I would re-emphasize that all patients should be definitely as a protocol screened for hepatitis B and C
PNC.
because we are giving potentially hepatotoxic drugs.
Yes,
So
sir.
even when you give sulfasalazine, there is a certain element of hepatotoxicity and bone marrow suppression also.
Yes.
Is there any precaution that you would advise the patient when on sulfasalazine, say prior to surgery, because of certain action of sulfasalazine? It acts on the platelets also, so it's
Okay.
a moderate degree of antiplatelet action. So it
Okay.
might marginally, but it's not very significant or accepted. What else would you like to screen this patient for? Because, like you said, now
Sir,
this patient it's an advanced disease. I think
yes,
you
sir.
agree on that.
Yes, sir.
Nearly
Yes.
23 years.
Yes,
So,
sir.
as a physician, what do you expect? Do you believe that, should we consider, and she could have advanced joint disease also, where the damage
Yes, sir.
index is very high.
Yes, sir.
So, would you consider any replacement surgeries for her?
Sir, replacements at present patient doesn't have any severe deformities, sir. So initial
Yeah.
stages we can go for splints and occupational
Yeah,
therapy.
fair enough. Fair enough. What I
Yes.
mean is, even the replacement in India, we don't generally go to the elbow and that. Essentially, we should. I mean, in your answer as a student, I think it would be wise to say that we screen for the knees and the hips.
Yes.
If
Yes.
required, we'd go for replacement if it especially improves the quality of life for
Yes.
this. And
Yes.
now that you're considering TNF alpha blockers or biological demands, biological synthetic demands.
Yes, sir.
So, so we can categorize demands into conventional synthetic,
Con-
biological synthetic, and targeted synthetic.
yes, sir.
Right? So,
Yes,
in
sir.
this patient, can we consider biological and targeted synthetic?
Yes, sir. We can consider because patient already used conventional DMARDs initially.
Right.
But you also need to see whether he or she was compliant or not. For
Sir,
example,
initially she was not compliant, sir. She came to us 4 months back. We started again on actually methotrexate, and recently 1 month back we have started her on targeted synthetic DMARDs.
We'll have to conclude, huh? Yeah,
Right.
Dr.
Right.
Ghoshi and Dr. Aditya. Yeah.
Yeah. So finally, Dr. Manaswini, I think
Yes.
nice presentation. Of course, you can go on and on with it. So finally, what is this patient on? What is she getting?
Sir, patient is getting tofacitinib, sir, and methotrexate 10 mg once a week, and folic acid and NSAIDs SOS.
Don't you give, say, pantoprazole or something along with this? Because is the patient able to tolerate this?
Yes, sir. Patient is able to tolerate.
Able to tolerate it. Fair enough. And why did you opt for a lower dose of methotrexate?
Sir, actually we have started her on tofacitinib, and then we lowered. Initially patient was on 25 mg once a week, sir. So we have added tofacitinib and we decreased the dose of methotrexate.
Yeah.
but
Do you feel the response is good?
Yes, sir. She came back after 1 month of starting tofacitinib, sir, recently. Initially, patient was in flare with TJC tender joint count of 10 and swollen joint count of 6. Right now it is only 2 tender joints and 1 swollen joints.
Any screening precautions with tofacitinib that would
Sir,
be
we
common
have
with TNF alpha?
sir, IGRA we have done, sir.
Right.
And
So
we
what
have
is yeah?
Sir?
What if IGRA comes positive? Let's say IGRA comes positive and you screen for like COX. I mean, you do X-rays also. It is negative. What will you do?
Sir, we can start 6-month dose of isoniazid or 3-month dose of rifampicin plus isoniazid in this patient.
No, but then what about tofacitinib? When to start?
Tofacitinib, I think we can start after.
Yeah.
I think.
Should we wait for 6 months or?
No, sir. 4 weeks we can wait.
Okay. Yeah. Within 1 month you can start along with
Yes, sir.
along with AKT, along with the screening. I mean, along with HR for 3 months or H for 6 months. You can start.
Yes, sir. Yes, sir.
Within a month.
Okay, sir.
And what
Right,
if
doctor?
active COX? Then what will you do? For
Sir, active COX, we have to start the whole regimen, sir, and we have to wait at least the intensive phase is over till we start.
Right.
Yeah.
Right.
I think we'll conclude and just give a short feedback, then we'll start with the next session.
Ma'am, verbal feedback?
Yeah, just tell her in 1 or 2 lines.
So Dr. Manaswini, my feedback is that yes, it was a nice presentation. But you know, what happens is when you have a very classical case, the viva would probably get more difficult.
Yes, sir.
So you should probably prepare more in depth for such a viva, because you know, a classical case, it becomes obvious from the word go. Whereas if it has a little bit more, if it's a more, you know, like a complicated case with other issues coming up, then you know, the viva is more unconventional and probably higher scoring. But you did very well.
Okay.
And
Thank you, sir.
I think it was a nice experience, a nice one for me also. Thank you.
Thank you, sir.
Dr. Aditya?
Yes, ma'am. Yeah. Manaswini, you did good. Yeah.
Thank you, sir.
Manaswini, please stop sharing your slides. Yeah.
Yes, ma'am.
Yeah, thank you, Dr. Varghese Koshi and Dr. Aditya. It was an excellent case presentation. I'm sure the students really benefited today. Thank you very much. And do stay with us. Dr. Alakendu, sir, you're there? Hello.
I'm here.
Yeah, so I'll share your slides or what?
Let me try once more. Possibly
Yes,
I can do
yes,
some.
sure, yeah. So today we have a guest lecture by a very renowned and famous rheumatologist of the country, Dr. Alakendu Ghosh, sir. He needs no introduction, but I'll just tell in brief about him. He's the founder and head, Department of Clinical Immunology and Rheumatology at the Institute of Postgraduate Medical Education and Research, Kolkata. He has been the past president of Indian Rheumatology Association from 21 to 23. He received the APLAR Master Recipient Award very recently, last year in 2024. He has around 150 publications in many peer-reviewed journals. So we are really fortunate to have you with us here today. Today, sir will be speaking on vasculitis associated with connective tissue disorders. And to make it interesting, he'll be discussing it with different interesting cases. Over to you, sir. So you can go to slideshow.
Okay. Is it visible?
It is visible, but it is not a slideshow.
Sir, please press F5. F5 on your keyboard. F5.
F5. Okay.
On the very
F5.
first row of the keyboard.
Achha. F5.
F5. Yeah.
Oh, FY.
No, F5. F5. F1, F2, F3. Those are 11 keys over there. Click
The
on
top
F5.
row, sir. Top row of the laptop, sir.
Achha. No, it is F1. FI.
F5. F5. Sir, F for Polytrax.
F for Polytrax and I for India or 1?
Five,
Five.
sir. Number five. Number
Oh,
five.
number 5. Okay. Sorry.
Top row of the keyboard.
Okay, number 5.
Resume
F5.
slideshow.
Your screen shares. Still.
If not, sir, could you see the zoom scale at the bottom of the screen, bottom right of the screen?
Zoom scale.
There is a plus minus button over there. At the very bottom of the screen, PPT only. Plus minus. There is a scale of sliding scale is there.
Okay.
No. You removed the screen sharing, sir.
Okay.
Yeah, you got it now.
So now just go to the first slide.
First slide, yeah.
Just go to the first
Up
slide.
and down arrow. Yeah.
Yeah. Is it okay?
No, sir. You haven't shared as a slideshow, right? Can you see the button? Just you press just like a moment before the minus button at the bottom of the screen. There is a small button slideshow over there also as a shortcut. You can click on that.
So
The
just
first button from the right side.
Just beside 60%.
Yes, you can say. You can click on it. Correct. Exactly beside 60%. No. Click with the mouse, sir. No, sir. Use mouse. Don't touch it. I think there is an issue on the touch. Yes. Go on that.
Yeah.
Correct.
No, sir.
No. Just
Next
on
to
the left. One step before.
left to it. Yes.
On the
sir.
left. Correct.
Ion slide 3. Which one?
Yeah, the first one from the right.
Now that is slide 3 of 28. It's showing.
Just besides 60%.
It's on the right side, sir. Right side of the screen.
There is
Further.
only.
Yeah, just left to the left
Yes,
of
sir.
63%. To the left of that.
63 is yeah.
Move a slide left.
Slide left. That top-like sign.
Okay.
Right, sir. Left.
Left.
More left.
More left. Okay.
This one's.
No.
30 about 60. Acha.
60 के left का sir. पहला button.
Slide
60 वाले के left का. 60 के left का first button.
So not the number, sir. The white box. Yes, sir. That. Click.
Sir, you can just press F5 on computer.
Try.
Press F5.
F5, okay.
On the keyboard.
This one.
On the keyboard.
I am pressing F5.
No, sir. I think he has. It's best to click on this option only. Just the button on the left side of the 60%.
Okay.
So there is a cup-like structure. Just
projector like. No, don't click on that, sir. No issues. Click on any other part of the screen. Just get rid of this one.
Yeah.
Yes.
Click anywhere.
Yes.
Yeah. Now you click on the first button. There are 3 buttons placed. Just near to 60%.
Sir, just left.
Next one.
Sir.
To the right.
Third one. Third one,
sir. Third one from this button.
Yes.
Yeah. Got it. Click on that, sir. Click on that.
Yeah.
So you have to click on it again.
You need to click on it, sir.
Okay. Which one?
The third one.
Oh.
Yes.
Yes.
Correct. Please click on it.
Double click, sir.
No, it should be.
Something is happening wrong.
I think sir's cursor is moving too fast.
Ma'am, he is having touchscreen laptop also, so he's trying both the ways.
So please just click on that button there, which you can see the large slide one.
Okay.
You can rest your cursor there, sir, and then click on it. Because the cursor is
Okay.
moving too fast, I think. That is why the problem is happening. Yeah, yes.
This
Just
one.
click on it. Click on it, sir. Yep.
It has been pressed, I think so.
This is my first slide.
No, sir.
It's still not come. I think.
Prasad, should we run the slides then?
Prasad, just
Yeah.
take the slides from sir and you can share it on the.
No, I
Yeah.
have the
Sir,
slides.
sir, just press Shift F5. Shift plus F5.
F5.
On the
Shift,
keyboard.
shift and F5
Shift
together.
and F5 together, sir.
Sorry.
Shift and F5 together if you can.
Yeah. Shift and F5. Yeah.
Hmm.
Together.
Is it happening? No.
Okay. Another option. Go to slideshow menu at the top bar. There is slideshow menu at the top. Home, insert, design, animations. There is one slideshow menu, sir.
At the very beginning of the screen. Yeah. The first.
Yes,
The
at
first
the
line.
top of the screen, slideshow menu.
Yes, now it is coming.
No, that's ma'am's screen.
Should I start sharing, sir?
I think that will be better.
I think, can everybody see my slides?
Yes, yes, now we can
Yes,
see.
ma'am. Your screen is.
I think I'll just run it so you can start. Huh?
Yeah.
Yes, sir. Welcome, sir. Sorry for the few glitches. Please start. So, vasculitis assisted CDD. Yes, sir. I'll just change the slides whenever you say. Huh?
Okay. Okay.
It's not moving. Huh? Now, yeah. That's it.
Okay.
First slide. Is the first slide seen?
Okay. Okay. Yeah.
Yes, ma'am.
Yeah, please start. Yes.
Few disclosures. First is I'm extremely thankful to MRA for giving me the opportunity to share some of the interesting thoughts with all of you. And second disclosure, I always dislike this online presentation because of A, technical issue. B, I cannot see faces of the people who are in front of me. I cannot see or perceive their reaction. And especially for the trainees, I always love to be in front of them because until or unless I see their reaction, their input, we cannot, or myself cannot enrich. And certainly third parties, congratulations to Patil and Shashank for having the half marathon in the morning. I have seen that was exciting really. The topic of discussion is vasculitis in connective tissue disease. There are two components. One part is vasculitis and another part is connective tissue disease because we know vasculitis itself is a very challenging issue. So far the clinicians are concerned. One part is to diagnose this as a very life-threatening situation, cannot wait for investigations to come, cannot wait for tissue diagnosis to come, and we have to have a very, very insightful, critical, analytical mind as an internist to deal with vasculitis. Second part, certainly, is to immediately immunosuppress this one. And we need to have a very clear thought that I am confident that I have differentiated this from infection. That is the most, because devastating therapeutic option. One part is antibiotics, no immunosuppression, and another part is immediate immunosuppression. Cannot waste time with antibiotics and waiting for this one. And third part is certainly how long to continue this immunosuppression in the case of unqualified vasculitis, primary systemic vasculitis. But today's topic is certainly vasculitis in CTD. So that is another very interesting clinical situation which we usually come across, and especially in our clinical practice. Like, let's start with a case. This is a 22-year-old married female vomiting and abdominal pain for 3 months, presented to the outpatients clinic, and very, very difficult problem for the patient, and for the clinician, again, another very challenging. Baseline primary complete blood count, renal function test, liver function test, stool routine, apparently were all normal. So that was really challenge for the clinician to identify the cause. Cannot ignore that this is functional because pulse rate was more than 110. And the patient is really very concerned because her pain abdomen, vomiting, giving a real botheration. No associated headache, vertigo in reference to vomiting. No associated relevant prior history of drug intake. On and off low-grade fever for the last 15 days. Next one. So next one, please. Next slide, please.
Oh, yeah, it's not moving one.
Oh.
Ma'am, please page down.
Sorry, yeah, I'm doing that. Should
Page down, page down. Yeah.
Page down, no? Should I stop sharing again, do it?
No, not needed, ma'am. Or page up, try page up. Let's see if it is going back. Press escape. Nothing happened.
No. I think you have the slides, then you'll have to do.
Ma'am, please escape.
I'm doing that.
Nothing. Next. Let me see. I have the slide also.
डाल दे हाँ हाँ वो भी डाल दे
You're able to share, Prasad?
Yes, ma'am. Just give me a moment.
I think we can allow sir to present directly via PowerPoint with show. If he can control the slides over there directly.
Prasad, are you able to share or should I try again?
Ma'am, just give me a minute. I have done it on my side. Just sharing my screen.
Okay.
I got it.
भगवान का नया सेट है बहुत एक महीना पहना दिया इसलिए धो रही हूँ वो गंदा नहीं है जो भिगो यहाँ का पानी से निकालना
This meeting is being recorded.
Prasad, just mute the others.
मैं बाहर वाला
Not happening?
Right. Just a minute. Visible now?
Yeah, slideshow and go to slide 3. And mute the others, please. Yeah, slide 3.
Yes, ma'am.
Yeah, next slide. Yeah.
Yeah, right.
Yeah. Yes, sir.
So the
Yes.
patient required, before that,
Just the
before
previous slide.
previous one.
Yeah.
So patient got admitted and with conservative support, there was no improvement. And interestingly, and also very, very challenging to the clinician as well, upper GI endoscopy, colonoscopy normal, stool normal, USG abdomen, mild ascites non-contributory, but only CRP was raised. So only option left was to check for the imaging. Next slide, please. So went for imaging and contrast CT scan done. And interestingly, you will realize that the CT scan showed two interesting findings. One part is that here, this is target site, there is edema of the bowel wall, symmetric edema. And here, the mesenteric vessels are showing, this is called target sign, that's very characteristic. They are showing some comb sign, the increased vascularity of the mesenteric vessel. So this comb sign and target sign give us a clue that possibly we are dealing with vasculitis, GI vasculitis. Next, please. And went for with this target sign and comb sign, we naturally clinician has to thought for systemic lupus causing vasculitis because CRP was raised paradoxically. ANA done, it was 4+ homogeneous, dsDNA, RNPSM and SM3+. Urine routine showing a mild protein and less than 300 milligram, complements were low. So accumulating all these data and presented with an acute pain abdomen, the clinical diagnosis was lupus with GI vasculitis. And this is the situation where one has to react immediately and methylprednisolone 500 milligram for consecutive 3 days given and followed by oral prednisolone and injectable cyclophosphamide as a second immunosuppression, and patient recovered. Next, please. Next, please. So this is a clinical scenario which a majority of us have experienced, that patient presenting with only acute abdominal pain without any clinical clue for the underlying pathology, and all baseline investigations are coming one after another normal, and ultimately contrast CT gave us the clue that we are dealing with this, and from that point we had to work up the back for looking for lupus. So lupus clinically quiescent but having emergency of pain abdomen, but serologically active with low complements, with high dsDNA, with procalcitonin negative, and patient ANA was strongly positive. So this vasculitis secondary to connective tissue diseases are classified under the category of vasculitis associated with systemic disease in the revised International Chapel Hill Consensus Conference nomenclature, may affect any of the small, medium, or large vessel, and usually portend a poor prognosis, affect around 10 to 20% of CTD. Next, please. Next one. And for the CTD, other than lupus vasculitis, we can get vasculitis in rheumatoid, 3.6 per million, or you can get in Sjogren's disease, relapsing polychondritis, or idiopathic inflammatory myositis. So around 10 to 30% patient can have associated vasculitis as a presentation, and we need to react immediately as an emergency situation. Next, please. So lupus vasculitis predominantly involves small vessel, more during active disease. 20% may precede other systemic feature, where majority of them presents with cutaneous lupus vasculitis, 90%, and visceral lupus vasculitis around 10%. Next, please. So for the cutaneous lupus vasculitis, 8% of cutaneous lupus presents with this vasculitic phenomenon. One is erythematous punctate lesion on the fingertip and palm, around 35-36%. Usually we get anti-Rho positivity. You can get palpable purpura in the form of cutaneous vasculitis, around 20%. And this could be a part or accompaniment of cryoglobulinic vasculitis as well as secondary inner setting of lupus, or very devastatingly progressive presenting phenomenon with antiphospholipid antibody positivity with this
Hello. So we can't hear you, I think. Hello.
I think, ma'am, he got disconnected.
Oh, you'll have to tell him.
Shall I call him, ma'am?
I'll just call him.
Hello. Next one, please. Yeah. Hello. Can you hear me?
Yes, sir. Now we can hear you. Yes, sir. Continue. Prasad, just change the slide. Yeah.
Oh, yeah. So this is these are the components of cutaneous vasculitis as a presentation. This is lividoreticular, especially in the setting of associated APS, or this one, as you know, is papillonodular lesion paniculitis, this tender finger nodule, splinter hemorrhage, or you can have a periangal infarct, gangrenous presentation associated with APS, or skin ulceration. These are the list which can be the manifestation of cutaneous vasculitic component in the setting of systemic lupus. Next one, please. So for the visceral lupus vasculitis, you can have other visceral involvement in the form of CNS involvement, though very rare. The most important differential diagnosis in that setting will be RCVS, reversible cerebral vasoconstriction syndrome. In the CNS vasculitis in the setting of lupus, we get smooth, intense, homogeneous enhancement. But in RCVS, there is minimal or no enhancement, minimal wall thickening. The differential would be atherosclerotic neurologic impact. Next one, please. Or you can get let's quickly finish the GI vasculitis. 80 to 85% cases affecting the ileum and jejunum. In our patient, ileum and jejunum were involved. Involvement of large bile is very infrequent, less frequent, 0.2 to 14.2%. It can be the initial presentation, around 50% of cases. Patient usually presents with vomiting, diarrhea. And the most important part, coexistence of lupus enteritis with cystitis. This is another very important accompaniment. We had around 14 patients who presented initially just with vomiting, diarrhea, and routine ultrasound examination documented hydroureter, hydronephrosis in absence of any obstructive pathology lower down. And these patients on workup diagnosed to have lupus, and they were having very high lupus activity, SLEDAI and BILAG, and required active aggressive immunosuppression. Next one, please. And the CT finding, as we have discussed, bowel wall thickening in the area that was distended maximally, and 5 millimeter for gastric wall, Turget sign. We can get comb sign, as we have discussed. dilatation of intestinal segment and engorgement of mesenteric vessels. Life-threatening complications like hemorrhage, infarct, perforation can develop. Despite successful treatment, lupus enteritis can relapse up to 30% cases with a mean interval between first and second attack around 2 years. Risk factors include large gut involvement and presence of cystitis. Next one, please. And digital necrosis is another lupus vasculitis in the setting of CTD. Around 5% patient can present with this one, and due to vasculitis, but also thromboembolism and atherosclerosis needs also to be excluded. Next one, please. And for the peripheral nervous system, this is another important one which can present with either peripheral neuropathy or emergency situation like mononeuritis multiplex, as were being discussed in the initial case presentation, can present with acute or sudden foot drop or wrist drop, and it could be only manifestation of lupus pain in 45% of cases. And histologically, there is axonal degeneration or depletion along with non-specific vascular changes or chronic perivascular or intraluminal infiltration. But we need to exclude other non-lupus related peripheral neuropathy, and that is the usual challenge in all patients of CNS, I mean neuropsychiatric lupus. The majority of the time the presentation is not due to lupus. So our responsibility or challenge is to exclude other non-SLE related causes and then stamp this one. And around 40% cases we can get non-lupus related clinical cause for this neurologic manifestation. Next one, please. Next is the renal vasculitis. Lupus nephritis is one of the major components of clinical sequelae, but renal vasculitis is very rare. The most common vascular abnormality found was the so-called lupus vasculopathy, deposition of eosinophil, pass positive material between the endothelium and media. Second more common vascular lesion was HUS-TTP, malignant hypertension-like injury characterized by intimal proliferation, lumen narrowing, wall edema, and thrombosis. So these are really very active, aggressive, emergency lupus manifestations required immediate hemodialysis along with filtration. High chance of progression to CKD. That is very important. Next one, please. Next, another very important and very devastatingly emergent situation is DAH. This is a part of pulmonary vasculitis. And when it is associated with glomerulonephritis, patient usually presents suddenly with severe anemia and streaky hemoptysis, chest excess shows bilateral ground glass infiltration and homogeneous opacities, and we are getting urinary active sediment. And with this urine active sediment, in the presence of urine active sediment, along with features suggestive of DAH, this is a part of lupus vasculitis, 1 to 5% lupus patient, and we need to exclude or rule out infection. But the most important part, mortality is so high, so we cannot wait for all investigations to come and give us the confidence. We need to have our clinical judgment immediately reacting, and we need to immediately rule out clinical infection and treat the patient with aggressive immunosuppression. And next, another important part is retinal vasculitis. Around 30% patient can present with vasculopathy due to complement activation and immune complex deposition with microangiopathy or severe vaso-occlusion associated with the presence of APS. Usually, retinal vessel sheathing is the main diagnostic sign. So these are the sheathing along with this white depositions, that is important cotton wool spot. There are retinal hemorrhages as well, and vascular occlusion may be seen. The pathogen like HIV, syphilis, tuberculosis, toxoplasmosis, cytomegalovirus, HSV needs to be ruled out who can mimic this type of manifestation. Next one, please. Next disease, most important part which can present with vasculitis phenomenon is Sjogren's syndrome. Nowadays, it's termed as Sjogren's disease, not a syndrome. And usually patient presents with, we know that when a patient presents in a female patient, presents with arthritis or arthralgia, having rheumatoid factor positive and antinuclear positive, but having no suggestions of rheumatoid arthritis and cannot be diagnosed as lupus, you need to look for Sjogren's disease. And there you can get Sika symptoms, and we need to look for the Sharma test. But these patients can present with an emergency situation like peripheral neuropathy with risk of fruit drop as a part of neurologic vasculitic underlying pathology, usually due to small vessel pathology. Medial vessel can present like pain in 5% cases. Most patient and common manifestation in this situation is palpable purpura. As we are talking, mononeuritis multiplex and peripheral symmetric sensory motor neuropathy is a part of vasculitis of vasa vasorum. Pure sensory neuropathy, sensory motor demyelinating polyneuropathy, and small fiber neuropathy in Sjogren's are not vasculitic in nature. We need to remember. Next one, please. So if we club this vasculitic manifestation in Sjogren's, it could be either organ specific, like cutaneous leukocytoclastic vasculitis, isolated peripheral mononeuritis multiplex, isolated CNS like multiple sclerosis, or can mimic isolated aortitis like Takayasu. Or for the systemic vasculitis, not organ specific, could be either immune complex mediated or medium vessel mediated. Next one, please. Next comes the cryoglobulinic vasculitis, another very important emergency situation. Few cases of vasculitic rash with hyper IgG levels were described previously. Hyper gamma globulinic vasculitis, sometimes associated with Waldenstrom macroglobulinemia. Most common type cryoglobulinic vasculitis. It is usually associated with Rho and La. It could be either a constitutional component, cutaneous components with purpura necrosis, or peripheral neuropathy, either mononeuritis multiplex or distal sensory motor neuropathy, CNS like multiple sclerosis mimicking a lupus, renal involvement, glomerulonephritis, or microscopic hematuria. Laboratory findings: ANA, rheumatoid factor, low C4 only, very characteristic of cryoglobulinemia, and mixed IgM variant of cryoglobulin could be positive. Hyperglobulinemia and leukopenia could be a part. Next one. So what usually we get? Usually we get this serum cryoglobulin precipitated after incubation at 4 to 8 degrees centigrade for 7 days from a primary Sjogren's syndrome associated with secondary cryoglobulinic vasculitis, can have a membranoproliferative glomerulonephritis, and there is expansion of esophageal matrix, and in combination with thickening and duplication of the glomerular basement membrane, producing typical histologic picture of double contour or tram tracking. Next one, please. And glomerulonephritis in older age and male patient are having the worst prognosis. High serum creatinine level and increased proteinuria also deepens the prognosis. Symptomatic lymphoma reported in around 5 to 20% of cryoglobulinic vasculitic patients within 10 years of diagnosis, with B-cell lymphoma of mucosa-associated lymphoid tissue mold being the most common among these B-cell lymphoma. Next, please. Next comes the rheumatoid vasculitis. It's not that common, and it is usually deforming rheumatoid arthritis, erosive, long-standing, in the setting of very high rheumatoid factor and very high anti-CCP, and patient if it's a smoker, and usually due to intimal and endothelial damage coupled with P53 mutation is responsible, and incidence is around 3.6 per million. And most important part again is to react immediately in that setting. Patient will require very high dose steroid, very high dose of immunosuppression in the form of cyclophosphamide or mycophenolate or Ritux, and hydroxychloroquine, low dose aspirin in addition to this aggressive immunosuppression may be a choice. Next one, please. And you can get skin manifestation around 90% cases, ischemic focal digital lesion, petechiae, purpura, ulcer, and pyoderma gangrenosum. A majority of all of us have experience in the setting of rheumatoid vasculitis. or erythema elevatum dilutum could be also a part. And you can get peripheral neuropathy in the form of mononeuritis multiplex, or systemic manifestation in the form of fever, weight loss, or we can get peripheral ulcerative keratitis, PUK. That is another very dreaded complication in the setting of rheumatoid vasculitis. Another organ may also be involved. Next one, please. Relapsing polychondritis. This is another very important situation, not that common. Usually presents with cutaneous leukocytoclastic vasculitis, can have systemic other major organ involvement in the form of CNS, PNS, GI, and cardiovascular or lung, and usually due to small, medium, or large vessel involvement. Idiopathic inflammatory myositis, though presents with a lot of autoantibodies with proximal muscle weakness, could be dermatomyositis or polymyositis or necrotitis. Usually vasculitis as an accompaniment, usually found in dermatomyositis, and prevalence is around 9.2 to 30%. And detection of anti-PL7 antibodies is associated with necrotizing vasculitis. But as we are talking, these are more and mostly common in the clinical setting of dermatomyositis. Next one. And last but not the least is scleroderma. Vasculitis in scleroderma is not that common, is very rarely reported. You can have vasculopathy, but inflammation is usually not that common. Few cases of CNS vasculitis have been reported. However, other vasculitis like ANCA-associated vasculitis, cryoglobulinemia vasculitis rarely been reported. Presence of ANCA has been observed in up to 11% of patients of scleroderma. MPO ANCA out of them. Presence of lung fibrosis and modulated by fibrotic predisposition in SSC. And vasculitis should be suspected in SSC patients with unusual manifestation like vasculitic ulcer or renal dysfunction in the absence of microangiopathic hemolytic anemia or normal blood pressure and ANCA positivity. So in that setting, if we get this vasculitic ulcer and renal decompensation, one should start thinking the etiology as vasculitis rather than other renal scleroderma renal crisis. Next one. So to summarize, the vasculitis in connective tissue diseases are very emergency situation developing in the setting of underlying connective tissue disease. SLE is the most common we have faced. We can get Sjogren's association, we can get MCTD association, in some situation rheumatoid, very rarely cryoglobulinemia, IIM, or relapsing polyarthritis. But for the treatment protocol, to summarize, the most important part is corticosteroid. Nowadays, the corticosteroid usage in lupus and other CTD has been reduced. And as we all know, corticosteroid usage in lupus, in renal flare, in neurologic flare, everywhere, we are using either maximum 250 milligram and reducing it to 0.5 milligram. But this is situation where we need to activate more as we are talking, and we have other options like cyclophosphamide is a very good option for our patient, and we can give other than cyclophosphamide, Ritax or anti-TNF or JAK inhibitor like this one. And to buy time in the situation where we cannot differentiate this from lupus activity or vasculitis versus infection, IVIG is a very good choice to tide over the crisis. Right, next one, please. So I think the most important message for vasculitis in the setting of connective tissue diseases are to identify very promptly so that you can have a very good clinical decision-making algorithm working in your mind, and so that you can react immediately. Otherwise, if we lose time, and time really matters in this clinical situation of vasculitis in CTD, and where you need to react very immediately, just getting the baseline blood report, if there is leukocytosis and if you can exclude infection, if you are getting raised creatinine with active sediment, this, if you get CRP in that setting where usually we get low CRP, these are the clinical pointer, baseline pointer to hunch and to look for vasculitis. Thank you. Thank you very much.
Thank you, sir. It was a very lucid lecture. Very sorry about the glitches with technical issues, but it was a very interesting lecture, very lucid presentation. I wanted to ask, how often have you used tocilizumab in vasculitic manifestations? And what were your results?
Very rarely, very rarely. In the majority of our patients who presents with organ-threatening clinical manifestations in lupus, majority of the time, methylprednisolone and cyclophosphamide was our choice in those situations.
And in scleroderma or overlap CTTs, sometimes it's really difficult to know whether it's vasculopathy or now it is they're having vasculitis, and then the dilemma is whether to give high dose pulse steroids or no.
Right.
The risk of flaring
That is the real
rises.
challenge. That is, yeah, exactly. Everybody is facing that one, and that's the dilemma. As we are talking, if we get in the setting of normal blood pressure, active urine sediment and rising creatinine, and in the setting of very high leukocyte count in absence of apparent or fluid infection, these are the situations where we need to think and redirect our thought process in reference to vasculitis rather than vasculopathy. Otherwise, majority of the time, scleroderma is really a very, very important challenge.
Varsha, Sandeep, you want to ask anything?
No, ma'am.
Sir, very lucid presentation, sir. Actually, I just wanted to, in a run-up to scleroderma, what about MCTD? So again, there would be a little bit of a challenge with MCTD coming with Raynaud's and digital gangrene, whether this is vasculopathy versus vasculitis. So what would be the reliable parameters to differentiate? As you've said already, leukocytosis is one of them.
And another part is possibly Nelfol capilloscope can give some clue. That's the only thing which can help at that setting. Otherwise, there will be really an overlap situation. And MCTD again is another very challenge. Nowadays, people again are going back. Do we really need to stamp this as MCTD or overlap like this situation? But for the digital gangrene, difficult digital gangrene, in addition to nifedipine or tadalafil, certainly we need to think for triprostanol, which can give us a clue in reference to vasodilatation actively. So that is again a very important clinical challenge as you told.
How much of immunosuppression, sir, would we use in this kind of situation?
Nah, the immunosuppression possibly won't hike in that way, because if there is no evidence of major organ in the form of CNS or renal like that one, possibly we do not get much benefit hiking the immunosuppression in that setting.
Thank you, sir.
Yeah. Dr. Koshi, would you like to ask any questions?
Yeah, ma'am. Sir, my question is regarding IVIG and plasmapheresis. Do you visualize or have you, in your experience, used it?
Yeah. Of course. IVIG, we have used a lot. We had to use a lot in the setting of lupus with major organ involvement, and we are in a dilemma just to buy time 5-6 days. IVIG was a very good option in those situations. And by that time, we could define the path, whether we need to go for the infection pathway or we have really excluded and have to go the immunosuppression. And plasmapheresis again is another option in the situation where there is a very high antibody titer we are presuming. And in that setting, plasmapheresis followed by hemodialysis was a very good option. So IVIG and plasmapheresis in this clinical situation is a very good armamentarium to be exploited as much as possible so that we can get the better outcome, of course.
Yes. If there is DAH, I think plasmapheresis would be better.
Pheresis is a very good option, of course. And DAH is, as all of us would appreciate, it's really very, very challenging. In the afternoon at 5 o'clock, just everything completed, going out, suddenly a patient came and strict hemoptysis, nothing more than that. And you cannot wait for the next days, and everything will be done by that time. So it's really a very important issue, meaningfully to be addressed in those clinical situations without waiting for investigations to come. Yeah.
Dr. Rajeshwari, ma'am, you're there? Ma'am, you would like to ask any question?
No, I was just revising all the topics, and as usual, an excellent and lucid presentation by sir.
Yeah, good to see you,
I
ma'am.
accept all the challenges he has said.
Mhm.
And one point to be noted is the scleroderma again. And
Mhm.
very often we always think it's only Raynaud's, but many a time dose of steroid, antibiotic, and anticoagulation helps them out a lot. And at that point of time, if it's only a digital gangrene, high dose immunosuppression may not really be needed permanently. The other thing is pulmonary hypertension, secondary to vasculitis, especially in MCTD and in lupus. Many a time the problem arises between APLA and vasculitis. So then it becomes a therapeutic challenge when there is no other way of distinguishing between both. In that case, it's better to try cyclophosphamide, and if they're going to respond, they do respond excellently within the first 3 doses of cyclo. And then obviously, that's going to be a vasculitis.
I
Anybody
fully
else?
agree with Dr. Rajesh. Yeah, pulmonary vasculature pathology is really another very important issue. And in our clinical setting, 3 or 4 patients we had to identify. And in those situations, in those days, Retax was available freely. So we tried with, in majority of patients were on cyclo. And these 3 patients, we had to try Retax. And with the first dose, there was significant improvement and reduction of pulmonary vascular resistance. Yes, of course, that's a very important and challenging situation in
In
reference to pulmonary vascular.
cyclo-resistant cases and in very severe variety of pulmonary hypertension, rituximab does work well.
Yeah,
It works well.
absolutely, absolutely. Retax should be the first choice. Yeah, I
So
mean, cyclo should be the first choice. Yeah, of course.
you give cyclo first, 1 dose, and then also give Ritux, right? So rituximab takes a little time to act, no?
Little time, yeah.
Yes. Anybody else would like to ask any questions? Okay. I think thank you, sir. Thank you so much for
Thank you
joining us
much.
today, spending your
Yeah,
time on a Sunday. Thank you, Dr. Koshi, Dr. Aditya, Dr. Rajeshwari, ma'am, and all the attendees today. I think we've had a good number of people listening to you, sir, today. Hope to see you
Thank you very
soon.
much.
Thank you once again.
Thank
And
you.
to compensate this pitfall, I need to go physically to Pune, of course.
Yes, sir. Please come to Pune. Most welcome. Yes, sir.
Thank you very much. Thank you very much. So nice of you.
Okay,
Thanks.
bye-bye,
Thanks.
sir. Bye, Rajeshwari,
Okay,
ma'am.
bye.
Yeah,
Bye.
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 Bye. Take
Bye.
care. Happy
Bye.
Sunday. Yeah. Thank you.